So we were studying about the initial investigation in case of dysphagia case and how the guidelines have changed now. So in case of dysphagia plus initial investigation, it would be endoscopy with exceptions of suspicion of pharyngeal pouch because of risk of perforation. Dysphagia plus diffuse esophageal spasm or achalasia, then most appropriate investigation would be barium swallow or manometry. Initial investigation would be endoscopy. Most appropriate would be barium swallow or manometry. Manometry is instead gold standard in case of diffuse esophageal spasm and achalasia. So most appropriate investigation is manometry. If it is not available, barium swallow. Most initial investigation is endoscopy. That should be remembered here. Let's move ahead. Now we have a 35-year-old woman who has sudden onset epigastric pain, chills and nausea. She gave birth to a healthy baby 2 days ago. Her blood pressure was normal throughout pregnancy. Her temperature is 37.8, blood pressure is 139/90, heart rate is 115. Urine analysis reveals no proteins. On examination, there is tenderness in right upper quadrant. ALP is 222, ALT is 55, bilirubin is 25, INR is 1, hemoglobin 101, platelet count 350, white cell count 15.5. So the single most likely diagnosis is being asked here. So this is a case of acute cholecystitis. The history of sudden onset epigastric pain, chills and nausea in the postpartum period with a likely history of an uneventful pregnancy makes cholecystitis the most likely diagnosis. There is a history of sudden onset epigastric pain and chills along with nausea in the postpartum period with likely history of an uneventful pregnancy. Due to this, cholecystitis becomes the most likely diagnosis. Symptomatic gallstone disease is the second most common abdominal emergency in pregnant women. Pregnancy alters bile composition and gallbladder emptying slows in the second trimester, increasing the risk of gallstones. So this is important that pregnancy alters the composition of bile as well as gallbladder emptying slows down in the second trimester of pregnancy. Therefore, there is increased risk of gallstones. In fact, symptomatic gallstone disease is the second most common abdominal emergency in pregnant women. Acute cholecystitis features include fever, local peritonism, elevated white cell count, an abdominal ultrasound if requested. It would confirm a thickened gallbladder wall with surrounding free fluid. As there is no protein in the urine and blood pressure has been normal throughout pregnancy, preeclampsia is unlikely here. There is no protein in the urine and also blood pressure has been normal throughout pregnancy. So preeclampsia is unlikely. Hemoglobin levels and platelet levels are within a normal range. For someone who just delivered a baby, HELP syndrome is therefore unlikely. Now, obstetric cholestasis may have aminotransferase levels as high as 20 times the normal limit. But the raised bile acids would cause significant pruritus, which would be the main presenting feature rather than epigastric pain. So in case of obstetric cholestasis, we will have pruritus as the main presenting feature. Pruritus or itching as the main significant feature rather than epigastric pain. because aminotransferase levels would be as high as 20 times the normal limit. And remember, alkaline phosphatase physiologically tends to be high in pregnancy. Yes, alkaline phosphatase in bone disorders as well as in pregnancy, alkaline phosphatase tends to be high. So here basically we are uh, looking at features like sudden epigastric pain, chills, nausea in postpartum period, and uneventful pregnancy. So cholecystitis is a likely diagnosis, and also we understood that symptomatic gallstone disease is the second most common abdominal emergency in pregnant women, and pregnancy alters the composition of bile, and gallbladder emptying also reduces in the second trimester, increasing the risk of gallstones, which can further lead to acute cholecystitis. Features include fever, local peritonism, and elevated white cell count. Abdominal ultrasound would confirm a thickened gallbladder wall with surrounding free fluid, shrunken gallbladder. Now, other things like preeclampsia, HELP syndrome, and obstetric cholestasis have been ruled out because in obstetric cholestasis, pruritus is the main presenting feature. Aminotransferase levels are as high as 20 times the normal limit, which is not the case here. Hemoglobin levels and platelet levels are normal here, so HELP syndrome is also ruled out. Another thing is that there is no protein in the urine, and blood pressure has been normal throughout the pregnancy, so preeclampsia is also ruled out. And alkaline phosphatase tends to be high in pregnancy. Now let's move ahead. Now we have a 34-year-old man presenting with slow progressive dysphagia. He has been using H2 blockers for the last year because of retrosternal discomfort. He has not noticed any weight loss. A hemoglobin level was done month ago which reads 13.3. What is the single most likely diagnosis here? Now there has been no weight loss, but there is slow progressive dysphagia. And so this dysphagia is due to peptic stricture. That is the answer here. Peptic strictures have an association with gastroesophageal reflux disease, and they can cause dysphagia. The fact that there is no weight loss and hemoglobin is normal points towards a benign cause. Esophageal cancer at this age group is also uncommon. The patient is 34 years, and also there is no history of weight loss. There is no the hemoglobin level is also quite normal, therefore it is not pointing towards esophageal cancer. So we have to see towards a benign cause of dysphagia, and because it is progressive as well, so it seems like a case of peptic stricture which have an association with GERD, gastroesophageal reflux disease, and cause dysphagia. These peptic strictures are formed due to chronic corrosion due to GERD, whereas in a case of Plummer-Vinson syndrome, we will have anemia and a beefy tongue along with esophageal web causing dysphagia. So in Plummer-Vinson syndrome, where iron deficiency is associated with a post-cricoid esophageal web. Plummer-Vinson syndrome is a condition where iron deficiency is associated with a post-cricoid esophageal web. So peptic strictures is the answer here, and it is the cause of progressive dysphagia in this case. Now let's move ahead. Now we have a 31-year-old man having history of passing loose stools for past 6 months. He says his stools contain a small amount of blood, mucus associated with abdominal pain. He has around 3 bowel movements in a day. There is no evidence of weight loss. Last blood result shows hemoglobin to be 92. Normal range is 130 to 180. So it is a little low. Hemoglobin is low. Colonoscopy was organized, which features are suggestive of ulcerative colitis. What is the single most appropriate treatment for his condition in this case? So as we studied, mesalazine would be the answer here in case of ulcerative colitis. The treatment for ulcerative colitis with mild to moderate symptoms is rectal mesalazine. That is topical mesalazine. Initially, we'll give rectal mesalazine, which can induce remission. We have to do two things: inducing remission and maintaining remission. Inducing remission by topical mesalazine, that is rectal mesalazine, which can induce remission and stop rectal bleeding. Iron deficiency anemia is also likely, so there is no harm in adding ferrous sulfate to his management. However, it is not the most appropriate one to select given that mesalazine is in the options. Diarrhea associated with ulcerative colitis can sometimes be treated with antidiarrheal drugs like loperamide hydrochloride, but its use is uncommon and is generally contradicted in patients with acute symptoms as there is a risk of developing toxic megacolon. So as we already studied earlier about management of ulcerative colitis, inducing remission and maintaining remission are the two things. In first line, we give topical aminosalicylates, that is rectal mesalazine, better than rectal steroids, and oral aminosalicylate. If not responding, add oral mesalazine, oral aminosalicylates. Still not responding, then add oral prednisolone. If there is severe colitis, then treat the patient in hospital with IV steroids as first line. How to see if it is severe colitis or not? 6 or more bowel movements in a day plus at least one of the following, such as temperature more than 37.8, tachycardia, temperature more than 37.8, ESR more than 30, tachycardiac, anemic. Maintaining remission is by oral aminosalicylates, that is mesalazine. If remission is not maintained, then consider giving oral azathioprine or mercaptopurine. That is how ulcerative colitis case is managed. So with mild to moderate symptoms, it is rectal mesalazine which helps in reducing remission and stopping rectal bleeding. But if iron deficiency anemia is also there, we can add ferrous sulfate to the treatment. There is no harm in that, but it is not the most appropriate one because we have mesalazine in the options here. Diarrhea which is associated with ulcerative colitis, can be managed with antidiarrheal drugs like loperamide hydrochloride, but it is contraindicated in patients with acute symptoms due to risk of developing toxic megacolon. So now let's move ahead. A 44-year-old man started having severe retching, vomiting, followed by interscapular and chest pain a few hours following an upper GI endoscopy. The following day, he develops fever, has a temperature of 38.9, respiratory rate 25, heart rate 110. On examination, subcutaneous emphysema on his chest is diagnosed. On examination, subcutaneous emphysema is found on his chest. So, what is the single most likely cause of his presentation? Likely cause of his presentation. So, here we have to understand that because there is a history of endoscopy, so there might be esophageal rupture looking at the picture of the patient. And one of the complications of esophageal rupture is mediastinitis. Mediastinitis is a complication of esophageal rupture. The pain is typically retrosternal When the lower mediastinum is involved, the pain can be interscapular and radiating to the chest. Subcutaneous emphysema is a late sign of esophageal perforation. Subcutaneous emphysema can be felt like Rice Krispies on the skin when pressed. They make crackling noises when touched, and patients can become very unwell and septic with an esophageal perforation. A good triad to remember for esophageal rupture is the Mackler's triad. That is a triad containing chest pain, vomiting, and emphysema. So the one thing which we have to remember here is about mediastinitis, which is the picture here, which is a complication of esophageal rupture, and the pain in that is typically retrosternal pain. When lower mediastinum is involved, then the pain can be interscapular and it radiates to the chest. Now, subcutaneous emphysema is a late sign of esophageal rupture, esophageal perforation, or esophageal rupture. In subcutaneous emphysema, we can feel Rice Krispies on the skin when pressed, and it makes crackling noises when touched. Patient can become very unwell and septic with an esophageal perforation. A good triad to remember for esophageal rupture is the Mackler's triad. In Mackler's triad includes chest pain, vomiting, and emphysema. Chest pain, vomiting, and emphysema. This is Mackler's triad in esophageal perforation or esophageal rupture. Pneumothorax can also present with subcutaneous emphysema, but it would not explain the vomiting or the reason that it follows an upper GI endoscopy. So pneumothorax can also lead to subcutaneous emphysema, but because this patient is having vomiting as well as there is a history of upper GI endoscopy, therefore it does not explain that. That is why here esophageal perforation, esophageal rupture is suspected, and it has led to mediastinitis, which is a complication of esophageal rupture. Having retrosternal pain, subcutaneous emphysema, which is a late sign. Mackler's triad is the main thing which we have to remember for esophageal rupture. Mackler's triad includes chest pain, vomiting, and emphysema, subcutaneous emphysema. This Mackler's triad is for esophageal rupture, esophageal perforation. It includes chest pain, vomiting, and subcutaneous emphysema. Let's move ahead. Now we have a 25-year-old woman having diarrhea and abdominal bloating over the last 4 months. On examination, she has blistering rashes over her elbows. Hemoglobin level is 105, mean cell volume is 79. On duodenal biopsy, there is shortening of the villi and lymphocytosis. What is the single most likely diagnosis here? So it says blistering rash over her elbows. This is called dermatitis herpetiformis, and dermatitis herpetiformis is a skin condition which is associated with celiac disease. Typical symptoms of dermatitis herpetiformis are red, raised patches, often with blisters and severe itching. The low hemoglobin is another clue towards celiac disease, as one of the most common presentations of celiac disease is iron deficiency anemia, Folate deficiency and B12 deficiency both can also occur. Shortening of villi, villus atrophy, crypt hyperplasia, lymphocytosis on duodenal jejunal biopsy provides us with the diagnosis of celiac disease. Serology would ideally be performed in primary care. This is likely omitted in the question as it would make the choice of the answer too easy. One may be thinking of tropical sprue as a diagnosis because it also has villus atrophy on duodenal or jejunal biopsy, has a similar presentation. However, it does not present with dermatitis herpetiformis, and it is also rarer as compared to celiac disease. So here we can have two differentials. One is celiac disease, another is tropical sprue. But because this patient is having a blistering rash over her elbows, this condition is called dermatitis herpetiformis, and this is associated with celiac disease. In this, there are red raised patches often with blisters and severe itching. And another clue here is low hemoglobin level, because one of the most common presentations of celiac disease is iron deficiency anemia. There can be folate deficiency and B12 deficiency as well. Now in endoscopic findings, we have short villi, that is villus atrophy, and lymphocytosis on endoscopy, duodenal or jejunal biopsy. Sorry, on duodenal or jejunal biopsy, we have villus atrophy, shortening of villi, and lymphocytosis. So it is dermatitis herpetiformis, which is letting us decide it is celiac disease, not tropical sprue, because their also presentation is quite similar. So this is a case of celiac disease. Let's study a little here about Whipple's disease here. Whipple's disease is a systemic bacterial infection which typically affects the GI system. Tropharema whippli is the causative pathogen, which once inoculated results in malabsorption throughout GI tract. Pathogen can affect other parts of the body such as heart, brain, skin, joints, where it causes non-deforming arthritis. So Whipple's disease is a systemic bacterial infection which is mainly affecting GI system. And the pathogen is Tropharema whippli. And it results in malabsorption throughout the GI tract. It also affects other parts of the body such as heart, brain, skin, joints, where it causes non-deforming arthritis. And we treat that with penicillin, tetracycline, and cotrimoxazole for 1 to 2 years. Okay, let's move ahead. Now we have a 44-year-old male admitted to the medical ward with complaints of diarrhea, abdominal pain, weight loss for the past few months. Examination notes finger clubbing, perianal skin tags, and abdominal tenderness. Colonoscopy reveals transmural granulomatous inflammation involving the ileocecal junction. What is the single most likely diagnosis here? So, transmural granulomatous inflammation involving the ileocecal junctions is one of the features seen in Crohn's disease. That is a characteristic feature of Crohn's disease. Colonoscopy revealing transmural granulomatous inflammation involving ileocecal junction. Now, Another quick fact here which we can learn is causes of clubbing, and it can be used by using mnemonic clubbing itself, like C for cyanotic heart diseases, Platelet uh, cyanotic heart disease, cystic fibrosis, then L for lung abscess, lung cancer, U for ulcerative colitis, and as well as Crohn's disease, then B for bronchiectasis and benign mesothelioma, I for infective bacterial endocarditis or idiopathic pulmonary fibrosis, N for neurogenic tumor, and G for GIT disease. So causes of clubbing can be remembered by using the mnemonic clubbing itself. C for cyanotic heart disease, Pilots tetralogy, cystic fibrosis, L for lung abscess, lung cancer, U for ulcerative colitis and Crohn's disease, B for bronchiectasis and benign mesothelioma. There are two B's, and I for infective endocarditis, then N for infective endocarditis as well as idiopathic pulmonary fibrosis, then N for neurogenic tumor, and G for GIT disease. Now let's move ahead. Now we have here a 38-year-old man complaining of crushing chest discomfort for 1 hour. That started when he drank a cold drink. He has no significant medical history. ECG shows sinus rhythm. He is given sublingual nitroglycerin in the emergency room, which improves his chest pain almost immediately. He has pulse of 70 per minute, blood pressure of 130/80, respiratory rate 18, cardiac enzymes came back negative. What is the single most likely diagnosis in this case? So this is a case of esophageal spasm, and the pain started when he drank a cold drink. And we know cold drinks precipitate esophageal spasm. Most likely answer here is esophageal spasm. So a case of diffuse esophageal spasm. As we know, in diffuse esophageal spasm, also known as distal esophageal spasm, the contractions are disorganized. Or it includes uncoordinated esophageal contractions. Diffuse esophageal spasm involves uncoordinated esophageal contractions. Presentation is dysphagia and intermittent unpredictable chest pain. Investigation, most initial is endoscopy, and even with dysphagia, second is esophageal manometry, which is the gold standard. Third is barium swallow, which shows corkscrew pattern. Treatment is with nitrates, calcium channel blockers like nifedipine, and botulinum toxin injection. So the esophageal contractions here are disorganized, so they do not lead to peristalsis or the forward flow of food. And clinical presentation includes dysphagia, intermittent and unpredictable chest pain. Pain can be so severe that sometimes it mimics myocardial infarction, and this pain can be precipitated by drinking cold liquids. Diagnosis is done by most initial investigation is endoscopy, Gold standard is esophageal manometry. It is the most accurate test, manometric studies. And another one investigation is barium studies, barium swallow, which shows a corkscrew pattern at the time of the spasm. Now treatment is by nitrates, then calcium channel blockers like nifedipine, and botulinum toxin injection. So this is about diffuse esophageal spasm. Now let's move ahead. Now we have a 50-year-old man who has severe pain on defecation. On examination, a tender reddish blue swelling is seen near the anal verge. What is the single most likely diagnosis here? So this is a case of perianal hematoma. Strictly speaking, perianal hematoma is actually a clotted venous saccule. It appears as 2 to 4 mm of dark blueberry purple colored under the skin at the anal margin. It is seen as swollen and actually tender perianal lumps. Now, management is it may be evacuated under local anesthesia or left to resolve spontaneously. First, incision and drainage of the clot relieves the pain, but the thrombosis often reoccurs and there may be persistent bleeding. Second is conservative management, which includes analgesia, ice packs, and stool softeners. A topical calcium antagonist may also help to relieve the pain. If managed conservatively, symptoms usually settle within 10 to 14 days. So, this is a case of perianal hematoma. Perianal hematoma is a clotted venous saccule. A clotted venous saccule. It appears like a 2 to 4 mm dark blueberry, purple in color, and it appears under the skin at the anal margin or anal verge. It is seen as swollen and it is actually tender perianal lump. It appears like a swollen and tender perianal lump. It is seen towards the anal verge or anal margin as a purplish dark blueberry like swelling under the skin at the anal margin, and it is swollen and acutely tender perianal lump. It appears like that. It is seen as swollen and acutely tender perianal lump. Perianal lump. Now, the management of this perianal hematoma or a clotted venous saccule management is it can either be evacuated under local anesthesia or it can be left to resolve spontaneously. So, how it is evacuated? So, in IND, incision and drainage of the clot helps in relieving the pain, but the thrombosis can occur again. We studied it is a clotted venous saccule, and there may also be persistent bleeding. Second is conservative management, which includes analgesia, ice packing, and stool softeners. A topical calcium antagonist may help in relieving the pain, and if managed conservatively, symptoms can settle within 10 to 14 days. So this is about perianal hematoma, which is a clotted venous saccule appearing as a dark blueberry-like swelling under the skin at the anal margin or anal verge, 2 to 4 mm in size, appearing as swollen and acutely tender perianal lump. Now we'll take break, short break, and I'll be back. So now we have a 35-year-old female presenting with secondary amenorrhea, and her blood tests are serum bilirubin is 42, ALT is 115, AST is 89, ALP is 189. Single most likely diagnosis is being asked here. So the patient is having secondary amenorrhea. Along with that, blood tests are given. So here we have to study about autoimmune hepatitis. The combination of deranged LFTs combined with secondary amenorrhea in a young female strongly suggests autoimmune hepatitis. So this is an important line here. The combination of deranged LFTs combined with secondary amenorrhea in a young female strongly suggests autoimmune hepatitis. In autoimmune hepatitis, serum aminotransferases such as aspartate aminotransferase AST and alanine aminotransferase ALT both are usually elevated at the initial presentation. Serum alkaline phosphatase is normal or only mildly raised. More than two-fold elevation suggests an alternative or additional diagnosis. Occasionally, the question would include a form of another autoimmune disease such as Addison's disease or vitiligo or autoimmune thyroid disorder, as this may also be present with the autoimmune hepatitis condition. Autoimmune hepatitis is a chronic disease of unknown cause, characterized by continuing hepatocellular inflammation and necrosis, which tends to progress to cirrhosis. So, autoimmune hepatitis is a chronic disease of unknown cause, and it is characterized by continuous hepatocellular inflammation and necrosis, tending which further progresses to cirrhosis. It predominantly affects young or middle-aged women. Up to 40% it is present with acute hepatitis and signs of autoimmune disease such as fever, malaise, urticarial rash, polyarthritis, pleurisy, pulmonary infiltration, or glomerulonephritis. The remainder present with gradual jaundice or are asymptomatic, diagnosed incidentally with signs of chronic liver disease. Amenorrhea is common and the disease tends to attenuate during pregnancy. The investigations for this, the diagnosis rests on a combination of compatible biochemical, immunological, and histological features together with exclusion of other liver diseases. So we have to carry out compatible biochemical, immunological, and histological features. We have to observe them. The diagnosis rests on the combination of these features along with exclusion of other liver diseases. Associated diseases, concurrent autoimmune disorders occur in approximately 40% of the patients, and particularly autoimmune thyroid disorders. So this should be studied here. Concurrent autoimmune disorders occurring in approximately 40% of the patients, and particularly autoimmune thyroid disorders. So this is a case of autoimmune hepatitis and combination of deranged LFTs combined with secondary amenorrhea in a young female Deranged LFT combined with secondary amenorrhea in a young female strongly suggests autoimmune hepatitis. In this, AST and ALT will be elevated at the initial presentation, but ALP will only be mildly raised or even normal. If it is more than 2 times elevated, then there can be alternative or additional diagnosis. Other autoimmune conditions can also be present in the question associated with autoimmune hepatitis, like Addison's disease, vitiligo, or autoimmune thyroid disorders. This autoimmune hepatitis is a chronic disease of unknown cause characterized by continuous hepatocellular inflammation and necrosis tending to progress towards liver cirrhosis. It predominantly affects young or middle aged women, and up to 40% of them present with acute hepatitis. 40% of them present with acute hepatitis and signs of autoimmune disease such as fever, rashes, urticarial rashes, malaise, polyarthritis, then pleurisy, pulmonary infiltration, and glomerulonephritis. The remainder present with gradual jaundice or are asymptomatic and diagnosed incidentally with signs of chronic liver disease. Amenorrhea is common and disease tends to attenuate during the time of pregnancy. Diagnosis is done by a combination of compatible biochemical, immunological, histological features together with exclusion of other liver diseases, and concurrent autoimmune disorders occur in approximately 40% of the patients, particularly autoimmune thyroid disorders. So this is about autoimmune hepatitis. Let's see if we have a chart on this. Yes, we have a chart on this. Here we can see uh, here we can see clearly autoimmune hepatitis presentation is with fatigue, pruritus, jaundice, amenorrhea, associated with other autoimmune disorders, especially of thyroid. Investigations which we have to do are LFT, liver biopsy, anti-smooth muscle antibody, and treatment is with prednisolone and azathioprine. So, autoimmune hepatitis presentation we are seeing. Presentation includes fatigue. Autoimmune hepatitis presentation includes fatigue, pruritus, jaundice, amenorrhea, and associated with other autoimmune disorders such as thyroid disorders, mainly in 40% of the cases. So there is pruritus, jaundice, amenorrhea, fatigue, and association with other autoimmune disorders like thyroid disorders. Investigation LFT, liver biopsy, and anti-smooth muscle antibody. Treatment is with prednisolone and azathioprine. So that is about autoimmune hepatitis. Let's move ahead. Now we have a 15-year-old boy who has a 5-month history of watery stools and vague intermittent abdominal pain. He has no blood in his stools. On most days, he would defecate 4 times. Weight has dropped 47 kg 5 months ago to 43.5 kg currently. On palpation, there is mild tenderness at the right iliac fossa. So the pain is present in the right iliac fossa, and so this is a case of Crohn's disease, and Crohn's disease in children typically presents with abdominal pain, diarrhea, and weight loss. The right iliac fossa tenderness is due to ileitis, which is the most common place of inflammation in Crohn's disease. Crohn's disease, although it can involve any part of the GI tract, but ileum is the most commonly involved part. So, because of ileitis, there is pain in the right iliac fossa. Right iliac fossa tenderness, which is seen here. So, this is a case of Crohn's disease, typically presenting in children with abdominal pain, diarrhea, and weight loss. Now, in children, we have to compare both Crohn's disease and ulcerative colitis as well. So, Crohn's disease in children presents with abdominal pain, diarrhea, weight loss, and faltering growth, whereas ulcerative colitis in children presents with abdominal pain and bloody diarrhea. Crohn's disease as abdominal pain, diarrhea, weight loss, and faltering growth, affecting the growth of the child as well. Ulcerative colitis as abdominal pain and bloody diarrhea. So that is about the comparison. Now the question is directly asking the pathological change in Barrett's esophagus. As we already studied Barrett's esophagus, in this there is replacement of squamous epithelium to the columnar epithelium, which is seen in Barrett's esophagus, and we remembered it like the columns are coming, that is a tip, and it increases the risk of esophageal adenocarcinoma because of the metaplasia, because of the replacement of the squamous epithelium by metaplastic columnar epithelium. Now, now let's move further ahead. This was about Barrett's esophagus. Now we have a 19-year-old boy attending the hospital at 7:30 a.m. for his elective esophagogastroduodenoscopy, that is endoscopy, upper GI endoscopy, and he is scheduled to be first on the theater list. However, he admits to have eaten a few mint sweets 4 hours ago. Now he has also taken sips of water an hour ago. What is the single most appropriate action in this case? So what can be done here? So we can't, in these cases there can be other scenarios as well, like we can carry on with the endoscopy as planned, should not be done, cancel the procedure, not be done, inserting an NG tube to remove the gastric contents, no, administering loperamide, no. So because we have certain rules for carrying out endoscopy, so we can delay the procedure, we can reorganize the theater list so that he's last on the list. The standard advice for patients undergoing an elective upper GI endoscopy or esophagogastroduodenoscopy is not to eat 6 hours before the procedure. An empty stomach allows for the best view. Taking small amounts of clear fluid is safe up to 2 hours before the procedure. Given that he has just consumed a few sweets 4 hours ago and had some water an hour ago, it would be best to delay or defer this procedure until the late afternoon. The next person on the list could go first. This upper GI endoscopy or esophageal is not done under general anesthesia. It is done with either anesthetic throat spray or IV sedation. The patient would be conscious throughout the procedure. A clear view of the stomach is still needed, so patients are advised not to eat foods which include mints and gum 6 hours before the procedure. So, again, so about this thing, there are certain precautions which we have to take for carrying out endoscopy or esophageal. The standard advice given for patients undergoing that procedure is not to eat 6 hours before the procedure. Empty stomach allows for the best view. Taking a small amount of clear fluids is safe up to 2 hours before the procedure. Now, this patient consumed some sweets few 4 hours ago, so and had some water an hour ago, so it is best to delay the procedure a little and the next person could go. for the procedure. First, this procedure of esophagogastroduodenoscopy is not done under general anesthesia. It is done with either anesthetic throat sprays or IV sedation, not under general anesthesia. The patient would be conscious throughout the procedure. The patient would be conscious throughout the procedure, and the clear view of stomach is still needed. Patients are advised not to eat foods including mints and gum 6 hours before the procedure. That is about this, and let's move further. Now we have a 35-year-old male presenting to GP with the complaint of diarrhea. He complains he has been having recurrent chronic diarrhea for the past 5 months. He claims to not have noticed any discernible pattern. He does not smoke, is a teetotaler. Upon examination, the patient's clothing appears to be ill-fitting. A blood test was subsequently done and it revealed the following: that hemoglobin was a little low, 118, mean cell volume was 106, little high. Peripheral blood film is significant for a dimorphic picture of red cells. Following the results of the blood test, the patient was booked for an endoscopy. Few tissue samples were taken during the endoscopy and for histology evaluation. Now, what is the single most likely pathology to be seen on histology? So, the thing which is being asked is single most likely pathology which is to be seen on histology. So, the diagnosis here is celiac disease. The man is suffering from celiac disease, and malabsorption typically presents with diarrhea and weight loss, and both are significant here. The patient's clothing appears to be ill-fitting, and that means there has been weight loss, and the patient is already complaining of diarrhea. The malabsorption from celiac disease can result in either iron deficiency, folate deficiency, or vitamin B12 deficiency anemias. In this case, since MCV is high, it is likely folate deficiency or B12 deficiency. More often folate. The term dimorphic red blood cells are used when one observes two types of distinct morphology in the circulating red cell population. It is seen in both B12 as well as folate deficiencies, and in sideroblastic anemia, post transfusions, myelodysplasia, and iron deficiencies. So these dimorphic red blood cells are seen in B12 deficiency, folate deficiency, sideroblastic anemias, post transfusions, myelodysplasia, and iron deficiency. Celiac disease is confirmed by finding villus atrophy or small villi on small bowel biopsy, usually duodenum on endoscopy. It is likely that the GP would have sent of specific autoantibodies such as TTG, or that is tissue transglutaminase Ig antibodies, to investigate for celiac disease when ordering the initial blood test. The information was omitted as the answer would then be too obvious. So again, we have to remember that a patient with celiac disease can present with diarrhea and weight loss, because of actually typically presents with diarrhea and weight loss because of malabsorption. And this malabsorption can either result in iron deficiency, folate deficiency, or B12 deficiency anemias. The term dimorphic red blood cells are used when the two types of distinct populations, two types of distinct morphology in the red blood cell population is seen. And these dimorphic red blood cells are seen in B12 deficiency, folate deficiencies, sideroblastic anemia, post-transfusion, iron deficiency, myelodysplasia. Celiac disease is confirmed by finding villus atrophy, crypt hyperplasia, lymphocytosis. It is confirmed by finding these features like villus atrophy and crypt hyperplasia in on biopsy, on small bowel biopsy, usually duodenum or jejunum biopsy by endoscopy. Now it is likely that initially itself specific autoantibody tests have been done by the GP, like tissue transglutaminase autoantibody, that is Ig antibody, or anti-endomysial antibodies for celiac disease. But it is not necessary that all the information will be in the question. Otherwise, it will be very easy then. So, diarrhea here, as well as the blood test and history of weight loss, and after that it is being asked about endoscopy and the dimorphic picture. All of these things are pointing towards celiac disease. Now let's move ahead. Now we have a 25-year-old woman who is brought into the emergency department after ingestion of 42 paracetamol tablets after receiving news that she failed her medical exams. She is confused and disoriented. She is regretful of her actions. She was admitted in the medical ward and N-acetylcysteine was given. 24 hours later, her lab results show ALT to be 159, ALP is 180, arterial pH is 7.2, serum creatinine is 263. What is the single most appropriate management in this case? Now, in this case, her arterial pH is 7.2, which is an indication for liver transplantation. She would need to be transferred to a liver specialist center. King's College Hospital criteria for liver transplantation or paracetamol liver failure is if arterial pH is less than 7.3, 24 hours after ingestion, or all of the following, that is, prothrombin time is more than 100 seconds, creatinine is more than 300, and grade 3 or grade 4 encephalopathy. In all these cases, liver transplantation is considered. So this criteria is important here. This is the King's College Hospital criteria for liver transplantation or paracetamol liver failure. So what is the King's College Hospital criteria for liver transplantation? Arterial pH less than 7.3, 24 hours after ingestion. Either this or all of the following things. That is, prothrombin time is more than 100 seconds, creatinine is more than 300 micromole per liter, grade 3 or grade 4 encephalopathy. So either pH is less than 7 point, arterial pH is less than 7.3 for 24 hours, 24 hours after the ingestion of paracetamol tablets. If arterial pH is less than 7.3, either this should be the criteria, either this should be fulfilled, or all of the three things, that is prothrombin time more than 100 seconds, creatinine more than 300 micromole per liter, and grade 3 or grade 4 encephalopathy. This is the King's College Hospital criteria for liver transplantation or paracetamol liver failure. In this case, because arterial pH is 7.2, that is less than 7.3, and that is even after 24 hours of ingestion. Therefore, this is a criteria. The criteria is fulfilled for liver transplantation according to King's College Hospital criteria. Therefore, the patient needs to be referred to a liver specialist center. Now let's move further. Now, how can we differentiate between grade 3 encephalopathy and grade 4 encephalopathy? In grade 3 encephalopathy, there will be marked confusion, incoherent speech, sleeping but arousable. In grade 4 encephalopathy, there will be coma, unresponsiveness to pain, unresponsive to pain. Maximum dose of paracetamol in adult is 4 gram. Ingestion of 5 gram causes liver damage in high risk patients, that is alcoholic ingestion. Alcoholic patients, ingestion of 10 gram will cause liver and renal damage. The liver damage is maximum at 3 to 4 days, which may lead to coma and death. In children more than 6 years, an adult serious toxicity is unlikely if dose is less than 75 milligram per kg, taken in less than 1 hour. That is additional fact. Now let's move ahead. Now we have an 8-year-old child presenting with recurrent abdominal pain. He has had 3 episodes of abdominal pain within the last 3 months, and it is severe enough to affect his activity in school. The abdominal pain is intense, located periumbilically, lasting for a few hours, associated with nausea, episodic headaches. He maintains a good appetite, is an appropriate weight for his age. On examination, there were no significant findings. Full blood count, urea, and electrolytes were found to be normal. What is the single most appropriate next step in management? So, because the patient is already symptomatic, the abdominal pain is intense, so reassurance is out of question here. But the thing is, that is, in contrast, actually, that is the answer here. Although we might tend to think towards abdominal, getting an abdominal ultrasound done, but still reassurance would be the way to go. Let's go ahead with this further. So recurrent abdominal pain with episodic headaches in a child. with no abnormal finding on examination and investigation points toward a diagnosis of abdominal migraine. Now, it would be worth also performing a tissue transglutaminase or IgA for celiac disease and fecal calprotectin for inflammatory bowel disease as an extra step to really widen the differential scope. However, those are not options here. Abdominal migraines are a type of functional pain, usually characterized by having first paroxysmal episodes of intense acute periumbilical pain lasting hours. The pain is dull. The pain interferes with the normal activities. Child may miss school. The pain may be associated with nausea and vomiting, and it is not attributed to another disorder. Reassurance is all what is needed in this case. So, here the thing which we have to study about is abdominal migraine. Recurrent abdominal pain with episodic headaches in a child with no abnormal finding on examination and investigation points towards a diagnosis of abdominal migraine. Although we can perform a tissue transglutaminase Ig antibody for celiac disease or a fecal calprotectin for inflammatory bowel disease as an extra step to widen the differential scope, but we don't have those options here. Now, what we have to remember about abdominal migraine is that these abdominal migraines are a type of functional pain. It is characterized by having paroxysmal episodes of intense acute periumbilical pain lasting for hours. The pain is dull type. The pain interferes with normal activities. Child may miss going to school. Pain may be associated with nausea and vomiting, and it is not associated or not attributed to another disorder. And reassurance is all that is needed in this case. Let's see if we have a chart on this. Yes, so a child presenting with recurrent abdominal pain with episodic headaches but no abnormal finding on examination and investigation. The most likely diagnosis and how is this condition managed? The most likely diagnosis is abdominal migraine and it is managed by reassurance. So this is about abdominal migraine. Let's move further. Now we have a 21-year-old female presenting to the emergency department with a complaint of severe diarrhea. She says that she opens her bowels in excess of 8 times a day for the past week and that she has noticed her stool is covered in blood yesterday. She's extremely anxious, scared about the fact that she has bloody stool. She's afraid she could have colon cancer. On further questioning, she reveals that her grandfather passed away 5 years ago from colorectal carcinoma. She also complains of colicky abdominal pain and and an urgency to visit the toilet. Her medical history is significant for ulcerative colitis, but she takes sulfasalazine. On physical examination, the patient appears to be pale. Examination of her abdomen reveals tender abdomen with no palpable mass or distension. Heart rate is 100, temperature is 38. The single next best step in the patient's management is being asked here. So the patient here is suffering from an acute flare of ulcerative colitis. This question gives multiple clues that allude to the severity, such as bloody diarrhea, which is the hallmark of the disease of ulcerative colitis, and several bowel motions in a day, tachycardia, and pyrexia. The patient is having severe colitis here. Because first, the patient is having severe several bowel motions in a day, more than six clearly. Bloody diarrhea is there, tachycardia is there, fever, pyrexia is there. So, intravenous corticosteroids are used for the treatment of acute and severe ulcerative colitis. So, intravenous corticosteroids. IV corticosteroids are used for the treatment of acute and severe ulcerative colitis. This patient clearly displays signs and symptoms of severe exacerbation and should be referred to the medical team. Topical aminosalicylates and oral corticosteroids have its place in the management of mild to moderate exacerbation of the disease, but not in severe flare ups like this. We already studied that in case of severe flare ups, 6 or more bowel movements per day, plus at least one of the following, like temperature, pyrexia more than 37.8, tachycardiac, ESR more than 30, tachycardiac, anemic. So it is a case of severe colitis. And in that case, we will give IV steroids, IV corticosteroids, like IV hydrocortisone, is as the first line treatment. So IV hydrocortisone is the answer here because it is a case of severe colitis. All the topical aminosalicylates and oral corticosteroids have their place in the management of mild to moderate uh, exacerbation of the disease, but this is a case of severe flare up, severe exacerbation, as the patient is clearly having bloody diarrhea, which is a hallmark of the disease, plus several bowel motions in a day, along with tachycardia, pyrexia. Therefore, intravenous corticosteroids, IV hydrocortisone is used for the treatment. Let's move further now. A 50-year-old man comes to emergency with abdominal pain that began suddenly about 1 hour ago. The pain is now generalized, constant, and extremely severe. He lies motionless on the stretcher, is diaphoretic, has shallow, rapid breathing. His abdomen is rigid, very tender to deep palpation, and has guarding. X ray shows free air under the diaphragm. What is the single most likely diagnosis here? So, this is a case of perforated peptic ulcer. Uh, I'll just come back in a while. take a small break here.